So there we go. So physician's duty is to provide information, elicit and interpret the values of the patient, and articulate and persuade the patient as to what action will actually help the patient meet their values. And in terms of autonomy, since this is something we talk about a lot in the secular bioethics literature, the idea is that moral self-development of the patient is actually relevant to medical care. And here the physician actually is not on high sitting, right, and telling the patient what to do. It's not doctor's orders. Rather, the physician is a friend or a moral guide or a teacher, and together the patient and the physician come to the best course of action. I presented this before, that by and large, Muslim physicians lack in-depth knowledge about Islamic theology, law, epistemology, and I will argue often misapply constructs of Islamic law in their daily practice. And I would say, I echo a little bit with our previous presenter, that in the juridical councils there is a deference given to physicians, and sometimes they exactly don't know what their role is, but I don't think they should be dismissed. But there is this deference to medical expertise. Medicine has a hold over us culturally. The idea that you can resurrect, quote unquote, the dead. And that has some psychological effect upon jurists as well. So the question for this talk, presented by myself and Omar, is whether and when should one seek medical treatment? And the reason that we're looking at this question is we want to try to explicate how jurists think about sources of moral knowledge, what are their notions of certainty of knowledge, and then I want to really highlight, or Omar will highlight, the analytical gaze of jurists upon the perspective, with the perspective of what are the deliverables of medical science. Clinicians, I'm going to talk about this piece, also have this idea of sources of knowledge for clinical efficacy and health risks, and they also have notions of certainty about the evidence that they bring forth to make recommendations. We're going to conclude, both of us, with some commentary or where we think there are analogous patterns or parallel reasoning patterns within these two different disciplinary experts, and where we believe that the two disciplines can mutually inform one another. Particularly, and I'll tell you because you might not get to the end, as all talks go, that we think that epidemiology, this science, can help jurists make juridical assessments about the permissibility and impermissibility of actions, and that theological notions of harm coming from the juridical discipline can inform the bioethical practice of Muslim physicians. All right, so I'm going to turn over to Omar for the first part of the talk.
All right, Bismillah ar-Rahman ar-Rahim, alhamdulillah, wa sallallahu ala sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. Assalamu alaikum, everybody. So when we're looking at how the fuqaha or how Muslim jurists have treated this issue, the question of when is it obligatory or for a Muslim to actually seek out medical treatment. The paper that we wrote focused specifically on the Sunni schools, and that itself was quite a lot of literature. We didn't explore the Shi'i schools, which should be explored as well to see how their juristic reasoning, if it's similar or different from Sunnis. But when we focused on it, a couple of things came out. And one of the important points here is that the jurists really treated, it wasn't a straightforward question, obviously. This is the one where you do find a multiplicity of voices as well. Louder. Is this better? Louder? Yeah, I have a horrible problem with my voice. I cannot project my voice, inshallah. And the way they approached this issue, now there were similarities between all of the four schools of Sunni law, but nonetheless they came up with different answers on this question. So one of the main issues was, one of the main concerns of jurists were regarding the certainty regarding the efficacy, right, that's the correct word, efficacy, of the medical treatment. So for certain jurists that we found, if the treatment reached a level of certainty and regarding its efficacy, then the ruling for that patient or for that particular individual changed. And in some cases, some jurists felt it was obligatory at that stage for the patient to seek out medical treatment, and some jurists held that even at that stage it may not be. And so certainty was really something that was of a central concern. And now one of the things so this brings out about the issue of epistemology and what do they mean by certainty. And so if we look here, knowledge in the Islamic tradition is really, it refers to propositional knowledge, and the definition of knowledge in which this jurists are dealing with when they're deliberating over this issue is defined as a firm conviction that corresponds to the thing in itself, right, to use that Kantian terminology here. Al-i'tiqad al-jazm, so it's referring to a particular proposition that, and a firm conviction an individual has, but that conviction also has to correspond to the thing in itself as it exists in reality. So in other words, knowledge and truth are definitely conjoined in this definition here. If it doesn't, you can have a firm conviction, but if it doesn't correspond with the thing in itself, then it's not considered knowledge in that case. So, but obviously we have propositions that we hold on to and that we're certain of. But human beings also, not everything that we know is of equal valence in terms of certainty. The term al-dhann, right, refers to a conviction that is probable or presumptive in nature, and is defined also as a preponderant conviction, al-i'tiqad al-rajih. So there's no jazm. The difference here between knowledge and al-dhann is the difference in the conviction that is being held in this proposition. But also, it differs with the possibility of its contrary being true. And so al-dhann here refers to a belief. It's not as firmly held as in the case of knowledge, but it also, the possibility of the contrary of what you're holding to be true is there. And therefore, it's at a lower level. It's called al-dhann. If you were to quantify this, it would this is a crude quantification of this, but it would be a possibility of less than 50% or a highly probable. There's also ghalabatul dhann, a possibility of the proposition not being correct, to a merely probable possibility of it not being correct. So just kind of a spectrum that dhann refers to. Then literally in the middle you have what's called doubt or uncertainty, ashak, and that refers to the indecision between two contrary propositions, but which there's no, without determining one proposition over the other, without favoring one over the other. They're both equal, right, possibilities, and that's when a person has doubt over something. Now, so this is in general the framework that the jurists are using and the terminology that they're using. So when we say certainty to a jurist, it means in general, the framework that we've outlined here. Now, when we say certainty in the context of the medical sciences, does it mean the same thing, right? Does having is something highly probable? When we say does that mean the same thing when jurists are speaking? And does it one compare to what medical experts are deliberating over issue? So getting the terms right and making sure that they're referring to the same thing is a very important part of getting the two camps in dialogue. Also, what can you have certainty over is something that is a major issue. So Muslim jurists do hold empirical propositions. There's basically 6 categories. Empirical propositions that are known through sensory perceptions, al-mahsusat. These are propositions that a person may have certainty over, such as that the sun gives light or the snow is white. The second type of empirical proposition, al-mujarrabat, these are empirical propositions that are known through experience, right? So over repeated observations, can you have certainty over them? Muslims, theologians, philosophers, and logicians do state that yes, you can. A person can achieve certainty over them. Now, this is known through experience, and here's where the medical sciences and experimental sciences would come into play. Now, this is kind of a spectrum of knowledge, propositions, where they would fall, and diagramming what I just spoke about recently here. So you can be certain that a proposition is false. You can be certain that a proposition is true. So certainty and the truthfulness of a claim, right? They're not necessarily real. You can be certain that yes, it's not snowing outside, and that's something you're certain of, or that it is snowing outside, and you know that's a false proposition, right? Thank God it's not snowing right now. And you can be doubtful as well. And so this is a general framework that Muslim jurists, Muslim theologians, when they're deliberating over issues, these are the terminologies, the terms that they're using, and this is what they intend by these terms. And so it's important when trying to translate between two different worlds, so to speak, or two different disciplines, that the terminology is gotten right. Should we continue on? Yeah. So, we talked about the issue of certainty regarding the efficacy of medical treatment. Another important dimension of Muslim jurist discourse was the issue of trust and reliance on God, a tawakkul. This was also a major part of their reasoning when coming to a ruling regarding this question: when is it obligatory that a Muslim should seek out medical treatment? And the tension is really caused, again, you find a difference of opinion here. So by and large, the Hanbali jurists kind of represent one end of the spectrum, and their position was really, they in general preferred that a Muslim trust in God and not seek out medical treatment. That was their general recommendation and the general position of their school. You have other jurists of the other three schools who held really the seeking out of medical treatment does in no way pose a problem or jeopardize one's trust in God. It's actually a confirmation of one's trust in God. So you have two ends of the spectrum here amongst Muslims in terms of their position regarding seeking out medical treatment, and does it or does it not negate one's trust or tawakkul in God. Now, why did this come about? Well, there's certain tensions regarding the texts that have generated this different understanding. So one is that there's a hadith of the Prophet ﷺ where he says that he praised individuals who will be going into paradise before anybody else, and then they asked for his what were the qualities of these individuals. And he described them in the following manner: that they have never allowed themselves to be treated by cauterization, nor divined the future by observing birds in flight. This was a practice of pre-Islamic Arabs. Nor have restored to the magician's charms. Rather, they have put their trust in God alone. So this statement of the Prophet is really showing how high trusting in God is. And it also mentions the very first thing, cauterization, which was a common method of treating individuals medically. And so it's showing here that they never allowed themselves to be cauterized, and yet they placed their trust in God. So this is one statement of the Prophet that shows, but this statement is more supporting the Hanbali school and how they preferred this statement over other statements. And this is the second one where the Prophet ﷺ mentioned that, seek out medical treatment. He actually encouraged, well, how do you interpret this now? Depends on, will determine the differences. You can interpret this as an obligation. You can interpret this as a recommendation, like seeking out medical treatment is just general advice. These are the different interpretive possibilities that exist. So he says, seek out medical treatment for except senility. God has not created an illness except that he also created its cure. So jurists have taken this statement and given a preference to say, seeking out medical treatment is actually a sign of trusting in God's providence. And so it's in no way contradictory to the two, nor does it jeopardize one's trust in God. So trust, or tawakkul, is defined, as one of the theologians defined it as confidence in God's providence, athikatu bima indallah, and renouncing what people possess, wal ya'su bima indan nas. So this is how they understood what tawakkul to be. But this was an important part of their discussion. It's not something that the jurists ignored. And we see here actually an issue of theology coming into play in the legal discourse here, and how it's impacting the decision of jurists regarding the question, should a Muslim seek out medical treatment, or when should they, or is it obligatory? So there's a lot more factors here that are involved in this issue. So then this is a question they ask: does taking means entail a violation of placing one's trust in God? Many ascetics and Sufis, they've understood, trust to entail that a person must not take any means to alter their condition. Whatever condition they're in, they must not voluntarily undertake any means to change that condition. It's all from God. And if you were to do anything to change your condition, you're acting against God's decree. This was an understanding of early ascetics, and jurists were not happy with this. Many jurists were not happy with this position, and they argued contrary to this. So the whole issue comes about with medical treatment. If it's a particular means to change your condition, right, then is that considered going against God's decree. And so, while all scholars agree that medical treatment is a permissible act, so even the Hanbali school, they will say it is permissible to seek out medical treatment, right? Different positions were taken over what the preferred course of action for a Muslim would be, in light of their position on tawakkul and relying on God, and in light of their position on the efficacy of treatment as well. So we kind of see these three streams coming into play on this question. We see law, we see medical science, right? And this was what's referred to in the previous talk of tahqiq al-manat, where physicians have a role to play. And really in this question, physicians' role would be what is the degree of certainty over this particular treatment? Whatever that's determined to be, that's when we can tell a patient you have to take this or you don't have to take this medical treatment. And then the issue of the virtue of trust, and that also comes into play as well. So this is the general breakdown of all the four schools. You can see here all of them held it to be generally permissible for a Muslim to seek medical treatment. The question is there a scenario when it becomes an obligation? Yes, except for the Hanbali school. The Hanbalis held that in all cases there wouldn't be there's no scenario for them. Even if you're certain of the treatment, it would still be preferable to not take it and trust in God. And does it violate trust, to seek it? No. If it's permissible, it doesn't constitute a violation of trusting in God. And then there are other details too that you can see here. Now, the important point to keep in mind here is we're just looking at one issue, and that is the efficacy of treatment and the certainty over that efficacy in determining when is it an obligation for a Muslim to seek out medical treatment. Jurists have discussed many other factors that, besides the efficacy alone, or other than efficacy, that would make it an obligation. And just as a quick example, Maliki jurists have discussed, for example, when if there's an individual and he's sick, but the community depends on him or her, right? Let's say there's only one heart surgeon in the community, and that person gets sick, they would have to seek out medical treatment in order to for their sickness, because the community depends on their services and their skill set. And if they were not to, and then they were to happen to die, or they would be in a state where they would be unable to carry out their function in society, then that would bring harm to the greater community as well. So they really, according to many jurists, that would also be an obligation, even if if no certainty exists regarding the efficacy of that treatment. So there's multiple other factors, and it's a very complex discourse actually of different factors and different scenarios in answering this question. What we looked at is just one issue, which is certainty regarding the efficacy of a medical treatment and its role in determining when is it obligatory for a Muslim to seek out medical treatment. All right.
So as far as this working group, we were dealing with different types of knowledge, and I thought what would be beneficial for this group would be to work through, and Omar only presented a couple of these categories, but from Imam al-Ghazali, about the different types of knowledge, the 6 types of knowledge that one can get certainty over. And one of the beneficial things is when you interact with jurists, you can see how that's reflected in your own your medical practice. So I'm going to work through an example with all of you. This is a table here about a claim by a patient and a physician in their sort of dialogue. So where is this? I have to find it. Hold on one second. So scenario is imagine a 15-year-old patient with abdominal pain that has migrated from the periumbilical area to the right lower quadrant over the past day. The patient reports nausea, anorexia, and fever. Right? So the patient reports nausea, anorexia, and fever, and pain. So that's the claim made by the patient. The question is whether this claim can be known certainly through the Islamic tradition. Well, all of these states are inward states, right? And according to that schema set up by Imam al-Ghazali, you could classify them as mushahadat al-batina, right? The internal states, inward states of an individual. And that can reach to a level of certainty. So that claim by a patient as a subject would be one that could be treated as certain knowledge. So then what happens is that the physician who is seeing that scenario says, well, I think that that patient has appendicitis. 15-year-old, migratory pain, fever, nausea, right? So they believe they're making a claim that the patient has appendicitis. So what sort of claim is that? Well, that claim is one made by associations. The physician has seen through the medical literature, through case reports, through their own experience, that this symptomatology is associated with the diagnosis of appendicitis. And that claim will be one based on the idea of al-mujarrabat, experiential knowledge, evidentiary claim made by seeing these things yourself or those of the community that you're involved in. And that can also reach a level of certitude. That physician then in the ED consults a surgeon. And that surgeon says to the patient, well, surgery will relieve your symptoms, these being the symptoms. And how does the surgeon make that claim? Well, he has seen or she has seen that through their practice or in the medical literature that doing the surgical procedure would relieve these symptoms, the pain, the nausea, and the anorexia. That claim also is based on associations from empirical knowledge, associations between two things that happen at the same time, and that can be treated as a certain claim. But what the surgeon is actually doing is not making the claim that surgery will relieve your pain, right? The surgeon is actually making the claim that without surgery, there will be certain morbidity and mortality to this patient, having them believe that appendicitis is a diagnosis. That can also be a claim from the same realm of knowledge, right, al-mujarrabat, and can be treated as certain knowledge, right? So that without surgery, that person will have certain types of morbidity and mortality. What's actually happening is that they're making two different claims. That I've seen people who have not had surgery, and they have certain types of morbidity and mortality. I am not making and that is juxtaposed with the claim that this person will benefit from surgery, right? So there are two different types of claims being made. In the end, the surgeon is also oftentimes, when we dialogue with patients, we make these very obnoxious sometimes claims that surgery is life-saving, right? And that can be a claim that one would say, okay, how is that physician making that claim? Is it that people will die without surgery and he's seen that, right? Or is he making the claim that, in this case, there is a mechanism claim from the hadithiyat, that the cause of that pain and that will lead to the death of the patient is a certain mechanism, right? That there is a swelling and an infection and an abscess in a certain part of the colon, right? And that the mechanism to remove that swelling and that abscess is surgery, right? That's one claim. And then they're saying, without that claim, that person will die. That will be a perforated appendix, and certain types of patients might then die. So one would say either the first claim in a certain patient would be certain, or it's a probable claim, right? That in a certain patient, certain characteristics, certain types of, we could say, certain types of profiles, that claim could be one that this person actually will die, right? But in other cases, the patient might actually survive. We know that there are many people, just from the medical perspective, that can be given antibiotics, right, for 2 weeks or 3 weeks, and then they will survive. They don't need the surgery, right? But the surgeon will then still say that because the next incidence might lead to death, I still want to take out your appendix. So the claim made by a physician is one never really brought out into what is the claim the physician is making to the patient. Oftentimes we just take what the physician is saying. But in the realm of understanding the claims through the types of knowledge, this is the sort of claim the physician is making. Now, that claim is then transposed upon the patient. The patient has to understand what the physician is saying. So if the physician is saying, or the surgeon is saying that surgery is life-saving, right, is the surgeon saying that, or is the surgeon saying that without surgery, death will occur, right? And you will have to acknowledge what sort of, you'll have to at least identify what sort of knowledge, what sort of claim they're making, and can the medical literature be invoked to make that claim? Meaning, that is the level of knowledge, of certainty about the association of death without treatment, one that is based on the evidence that exists in the literature. In the juridical discourse, you note, and Omar didn't present this, that different jurists had a different view of what was the responsibility of the patient vis-a-vis certainty of the medical treatment, and what is the responsibility of the physician. Some jurists accepted that a physician saying that this will be a certain life-saving treatment created an obligation in the moral agent being the patient. Others said no, that the patient themselves, through their own experience, has to know that that treatment is certain. And they cannot just accept the qawl of the physician. So these are different boundary points of how jurists took into account the evidence coming from the medical literature or in this case from the physician, and how they would then suppose upon the moral agent, in this case the patient, what they're supposed to do. So that's just a brief example. So how do we think about in our own practice the sources of knowledge in medicine? And this is, many of you are smiling, it's very familiar, so I'll buzz through it. But evidence-based medicine is in vogue these days, and the idea is that there are 4 steps. You have to clarify the clinical question, acquire the evidence that will help support addressing this question, appraise the evidence, and then apply that to the clinical scenario. So in our instance, when should a physician recommend treatment? One could say that the question would be, when are the risks of non-treatment of a medical condition significant enough to recommend treatment? Meaning without treatment, that person will have some sort of morbidity or mortality. At the same time, you could rephrase this question as, when are the benefits of treatment significant enough to outweigh the potential harms of therapy? Right? They're interrelated questions. What is the benefit of treatment? What is the harm of non-treatment? Right? So there's a quantitative assessment of risk, the risks of non-treatment, right, and a qualitative assessment of the significant harm that should occur in this particular patient would they not have had treatment. Moving on, so that's clarifying the question. Then we think about the going to literature, and the question is, first, let's take the evidence on the harms of non-treatment. And for the harms of non-treatment, I'm going to buzz through this classification system. We would think that the best place to go would be the longitudinal cohort studies, that you follow individuals who have not had treatment, right, and you look at the instances of morbidity and mortality in those patients. You're doing a natural history experiment of that disease. The next place today that we would find evidence on what the harms of non-treatment would be in the placebo-controlled groups of RCTs, right, where you have a treatment and a non-treatment arm. The non-treatment is followed, and you see what sorts of incidences of morbidity and mortality occur in that non-treatment group. Now there is, and I'll talk about this idea of placebo effect, but nonetheless that gives you evidence of a sort of natural history of that disease. The third level here would be case reports, right? So these case reports would then find patterns of disease course, symptoms that occur, and results of attempted treatments. After you look at that literature, you would then calculate the prevalence and the probability of each one of these harms, whether it's pain, which can be considered a harm in Islamic tradition, whether it's death, which is a harm in Islamic tradition. What is the specific incidence and prevalence of that in the certain patient population? Each one of these from the medical side has limitations. First of all, primarily is publication bias. Oftentimes, things aren't published in literature, and if there's no finding, what's the point? Right? So you might not get a true correspondence to reality from just looking at the medical literature. And oftentimes today, patients always try treatments, whether we know that or don't. Right? So a person might take Tylenol, they might go to a spiritual healer and do something, but they might not report that to a physician. So there's almost always treatment occurring, whether or not we have evidence of that. And then this idea, as I mentioned, of placebo effect, there's a large history of body literature that says that individuals who believe they are getting medicine have benefits even though they're not getting any medicine. But there is this belief aspect leads to some benefits for treatment. Okay. Step 3 and 4, I'll combine them because of the time limitations here. We have to appraise the literature and then apply it. So we just talked about the limitations of the data sources. Another limitation, I think, particularly for those involved in this question and answer with jurists, is do you have the requisite expertise to tease out the methodology of the research that's occurred, right, both statistically and the design of the study, to appraise the evidence? Oftentimes, we've noticed this phenomenon, and here I'm going to critique a bit the juridical councils, where a physician who might be from a different discipline is commenting on a different discipline. A neurosurgeon is talking about in vitro fertilization. Right? Do they have the expertise in that realm, first? Secondarily, do they have the expertise as a clinician, practicing in the clinic, or as a health researcher who can appraise the evidence? And what are you bringing forth to the jurists? And oftentimes, jurists don't look at that at all. They just accept on face value what that one physician has said. So from the physician side, we will then take the evidence and make a clinical recommendation. So this is one schema from, again, evidence-based medicine, that if you have levels of evidence that are 1 or greater, you would make a strong recommendation. Then if it's level 2, 3, 4, and I mentioned these previously, right, you would then make a recommendation or you would give the patient the option. Idea being here the deliberative model, that you state what the evidence basis is, you then articulate with the patient their values, and you come to some agreement about what you should do together. Okay, so I'm going to turn over to you again, and then we're going to close with some remarks.
All right, so we'll probably end on a more philosophical note, hopefully. You know, after having this interaction, oh, I need the PDF. After going through this interaction and this working group, you know, one of the things that we're using the word reason and reasoning, and you know, Charles Taylor in his work, The Sources of the Self. Oh, let's hold it. Is that better? So in his work, The Sources of the Self, he talks about a shift that happens in this notion of reasoning, and it's brought on to the Western world by Descartes, and he calls it Descartes' notion of disengaged reason. And what he means by that is that what he understands by this word rationally, and we're talking about, you know, reason, using this word reason, using the word rational, is that you know, this meaning of this word has changed, and it's had a major shift recently. Reason, in his understanding, he says, is no longer defined in terms of a vision of order in the cosmos, which is more of a Platonic notion of reasoning or reason. Rather, reason, this disengaged reason of Descartes, is defined procedurally in terms of instrumental efficacy or maximization of the value sought or self-consistency. And this is important because, I mean, my own thoughts going through this and looking at how, you know, the reasoning process and the mode of reasoning between the jurists and between medical experts, comparing them, I kind of felt that this was coming to light. Whereas when you look at the Muslim jurists, they were working with a particular vision of order, of hierarchy, of rank in the cosmos. Not all types of knowledge were of the same rank. Not all types of virtues were of the same rank. You know, not all, and so, you know, there was hierarchy in creation, and you kind of see that. You see the issue of trust being a major concern for Muslim jurists. You see efficacy of treatment being a major concern. You see this idea of the body and the rights of the body. All of these different streams of thought are coming into play when they're deliberating over this issue. And whereas when you come to the medical experts, it kind of seemed like all that is stripped away, and they kind of disembed, you know, themselves from all of, you know, this end order of the cosmos, and they're carrying on this reasoning for the same question, but in a very disengaged manner. So kind of, to me, you know, you can see that how this represents, you know, Descartes' understanding of a disengaged reason, as Charles Taylor would describe it, and whereas a Platonic notion of reasoning, which is embedded in the cosmos, or in an order, a vision of order in the cosmos. And in answering the same questions, depending on where people are coming from in their respective traditions, you're going to get different answers. And that's why this activity and this experience is very important, because as Muslims, we may not share the same vision of order of the cosmos as others. And so hence our answers and what matters to us would be different in that regard. All right, Jazakumullah khairan. Thank you so much.
So I'm an ER doc. I don't examine anybody, and I just do imaging, and we're done. No, yes, it's simplified, right? I mean, the point, obviously, in this short presentation, I didn't want to be the one who took longer time, right, to go through this. But I think your point is one that actually many people don't appreciate from the juridical tradition, that it is an art and not a science. They treat this, they don't understand this idea that a recommendation is a recommendation, but what's the weightedness of it? And on the same time, physicians don't recognize that either. Oh, you must do this, right? So that's why you see in the bioethics literature, maslaha or dhurura, khalas, that's it, right? Either everything's public benefit or everything's a dire necessity. And I think that's a problem because we don't have this idea of there's a lot of gray zone within what we're doing. And particularly, what I didn't mention here, which is so what I think one of the implications of the work that we have been embarking upon, is that this idea of what are the ethical values of a physician, right? We talked about primum non nocere, first do no harm. The idea of harm in this world, harm in the afterlife, and what does that mean for a physician when you say do no harm? I mean, if I have a supposition that someone has an appendicitis, as you said, they might look fine right now, but I'm thinking about an expected future harm, right? So does that mean I don't take them to the operation theater because I don't want to touch them until they're going to be on death's door? So I think the way that we think about medical practice is very sophisticated. It's not reflected in our literature and not to the jurists. And that's why you need better terms of dialogue. And one way to start is just evidence and sources of evidence, right? So this is how we've started the conversation.
One thought, that one variable that I'm sure you're probably going to talk about in the paper, but also another variable is the harm that comes from treatment. So in the pharmaceutical industry, I mean, the standard that we have is that you have to justify benefit risk to be able to have a drug that's actually viable and that you can actually put on the market. That's a regulatory definition. So this idea that any treatment that we do also has a potential harm. And if you step back from the big question that you're asking is, when do you reach this level of certainty that taking treatment actually becomes an obligation? That's a very high bar to meet when we think about almost any intervention. The other thought I'd share with you is the vast majority of interventions that we do on a daily basis in primary care are chronic disease management, where the certitude that there's a benefit to giving somebody a high blood pressure medicine is minuscule. I mean, there's no way that I would think it would meet the standard. It hurts me to say that, but the reality is it wouldn't. So again, just thoughts if you guys, I'm sure that you've grappled with this. I remember we had some conversations about it, but how you grappled with it in this context.
So obviously we've had conversations about this in our working group, and I'd like to get the other people, but I dealt with the first question, right? The risks of non-treatment, not the harm, the benefit, the second question here. What are the benefits of treatment significant? Are they significant enough to outweigh the potential harms of therapy? So we worked through the first question as an example. I think, and I'm going to push back on you since I can. I think that as Omar was presenting, that it's not a singular question. What's the efficacy of treatment that makes an obligation, right? He just presented an example that there are other factors that go into it about social functioning of that individual, right? There's a holistic vision of the human being, which I'll say we're going to work on a project about maqasid. What is that holistic vision of the human being? Does it map up to the biopsychosocial model or biopsychosocial spiritual model, right? So our law takes into account other things. And we're working at the level of fatwa here, but there is a vision. And oftentimes we just have a partial vision of what that is. So I think that will all come to fruition. And for those who are in this room, we all want quick answers today. And I just beg of you for patience. That's also a virtue. And we have to work together to get there.
As a psychiatrist, I believe that the guiding principles of treatment of mental illness perfectly matches with the Sharia. And I'll tell you about that. We are only obligated to treat a psychiatric patient if he is suicidal, if he is homicidal, or he fails to take care of himself. If he stops eating, not sleeping, not taking showers, he just totally isolated himself, and he is at risk of dying because of that. Those are the only conditions under which the law gives you the permission to take the patient's right and treat them involuntarily. Otherwise, I may have a patient sitting in front of me, actively psychotic. I can't put him in the hospital. That's perfectly matching with the Islamic ruling that the patient has the right, and as long as he's not going to be seriously harmed by this psychosis, he's still eating, he's still sleeping, he's taking care of his basic needs of his life. I mean, this human being has the right to refuse treatment.
So I'm going to say we cut out our slams on harm, but what you're saying I think shows the lack. So I agree with you 100%. But how many people would think about mental health treatment from an Islamic perspective, one that we should be doing? In the sense that you have this vision of mental health treatment, no evidence base for most of the stuff what you do, right? I mean, a minimum evidence base. Yeah, I'm just right. No, but you see, what comes to mind first? That they're trying to change someone's like. I'm just speaking from. I have actually data from patients on this, right? So I'm not being facetious with you, but they would say no evidence basis. They're trying to change someone's identity and personality and take away their rights, right? That's the vision from the public about mental health professionals when I in the ED do a mental health arrest. Yet what you just said is what we're thinking about. The harms that might accrue to themselves or others should they be left in the public sphere. So how many of us actually deal with that is what I'm saying. That we think about one side but not the other side. And I just appreciate your question. I'm not saying you're wrong. I'm just saying I appreciate that there is another side, another angle that we actually don't think about. But when you talk to the lady, they think about the other, the what is the bad side of mental health treatment.